Okay, everybody. As we wait for a few more attendees to join us, I think we should get started. We have quite a few of you on the line already. I don't want to make you wait any further. Dr. Pitt will be joining us in a few moments. So I'm Florent Saint-Clair. I'm the Executive Vice President for Dicom Systems, and I'm going to be conducting, hopefully as soon as Dr. Pitt joins us, more of a conversation with him about his perspective on AI and technology, generally speaking, in healthcare, because AI is really just the next generation of technology, and there's been a long dialogue between technology companies and healthcare professionals about what it takes to provide better healthcare for patients. And so Dr. Pitt will give us, his valuable perspective on what it takes as a physician to implement new technology. It doesn't matter how ambitious or how tech savvy a physician is. There's usually quite a few hoops that they need to jump through in order to adopt a new technology. So Dr. Pitt is a professor of neuroradiology at the Barrow Institute in Phoenix, Arizona. And he's also the CMO for Avisia, which is a telemedicine company based in Virginia. So he has a pretty unique perspective on both technology and obviously being a physician for a number of decades now. So our company, Dicom Systems, really briefly, is essentially designed to live at the intersection of IT and imaging. And so our perspective on AI, just so you understand how we came to be in this industry, is really as the plumbers who supply the de-identified medical images to the researchers, right? In order to teach an algorithm anything, you have to give it hundreds of thousands of images to learn from, and not just any images. They need to be de-identified carefully so that you don't provide any kind of security risk to the hospital. And also the ability to pool the information and train the algorithm on labeled data, right? You can't really learn anything from plain images. You really have to have labeled images. And so what occurs is something called, it's called trained deep learning, right? So it's a deep learning that takes place because a supervisor is actually working with the algorithm, right? It's giving it input that has been labeled. So over the hundreds of thousands of examples fed to an algorithm, they're going to be learning what a certain pathology looks like. So in terms of AI in the industry, it's an enormous industry at this time. And so you have a lot of investment going into it. And the staggering amount of investment is going into all kinds of companies, startups, as well as very well-established companies. And the result has been some deafening noise in the industry. I don't know if most of you probably go to the RSNA show, maybe to the HIMSS conference, and the SIM conference. Any of those conferences, all the advertising is pretty much painted AI. And so this very noisy industry, this very noisy marketplace is making it very difficult for physicians to, obviously first continue providing their the same level of healthcare. Alan, is that you?
It is. I'm so sorry for being late, Florent. I apologize.
No worry, no apology necessary. Everybody, Dr. Pitt is on the line with us, and so this dialogue will start in just a moment. So Alan, I'm just going through a few slides of intro to this conversation that provide the backdrop for the material that we're going to go through together. Okay, so very noisy marketplace and a lot of deals going through, and so that means that the noise is only going to intensify, right? Because all of these companies that have received venture capital or private equity money are going to be putting out products. And as they put out products, they're going to be expecting hospitals, clinics, radiologists, radiology groups, you name it, they're going to be expecting it expecting them to buy the technology from them. And what does it take to actually implement this technology is something that nobody's really talking about yet. And that's what I really want to dive into with Dr. Pitt, because being a clinician, being a neuroradiologist, in the trenches today, he can give us a unique perspective of, well, what technologies have you, in fact, been able to adopt in AI, if at all, and also, what are some of the hoops that you're going to need to jump through, even if you're a very strong physician leader in your organization? There are procedures in place, right? So the organization Dr. Pitt works in is Dignity Health in Phoenix, Arizona, and that's an enormous health system, which means that it's not just his decision or his choice to work with a certain algorithm or a certain technology. He's going to have to follow some procedures and some rules. And there are people that he reports to, and those people have people that they report to, a CIO, a CEO, and adoption of those technologies needs to be much more scrutinized than the industry is really talking about today. So all of the excitement around AI and development of AI is one thing, but how do we actually implement it? What does it take is what we should be talking about today. So Dr. Pitt, I'm going to kind of cold turkey introduce you into this context. You'd mentioned several times to me the case of the Glasgow Coma scale, which could have been a really interesting collaboration between tech and physicians, right? So here's a standard that's been around for 44 years, and imaging is not being considered. So would you jump into this?
Florent, by the way, thank you for the opportunity to talk to your audience. I very much need the help of the technology community. So I'm a lowly physician. I'm just trying to get through my day. But without the help of a adequate conversation between tech and healthcare, it becomes very difficult to develop the solutions that we need to take care of each other. So I can absolutely talk about the Glasgow Coma scale and some of our thoughts of what we had. I'd also really like to give folks an idea of how I evaluate technology and which might help you in design and what we need to do. But taking your question, the Glasgow Coma scale and some of the things that we were thinking about here at the Barrow into context, the Glasgow Coma scale is the way that most patients who come in with change in mental status or after some neurologic event, how we evaluate them as clinicians. And it's been around for decades. And it really is a very simple scale that looks at your responsiveness, how your body is being positioned, very simplistic and rapid way to assess somebody's neurologic status. But when the Glasgow Coma scale came out, imaging was really not a part of the Glasgow Coma scale evaluation because it didn't exist. And so one of our thoughts was, could we use AI and clinical data of the Glasgow Coma scale to better predict how someone's going to do in the hospital? Unfortunately, really, in my experience, looking at the vendor community right now, they're not really at the stage where image analysis via AI could help us. And I'm really looking forward to the day to do that. Just as an aside, what I need from imaging, what I need from AI in terms of imaging, is I need an imaging algorithm that would quickly assess a CT scan of the head. It would look for evidence for a fracture to the skull, a contusion to the brain parenchyma, and evidence for blood, both subarachnoid and extradural blood, the two types of blood. If that could quickly be done, I'm certain that given enough data, we could really start to use imaging as part of the Glasgow Coma scale. And I think we could effectively prognosticate and add treatment plans to patients if we were able to do that.
So that's an example of something very real that AI could potentially address, and really the underlying question behind this, right? This is an illustration of a much wider issue. there are some very real use cases that are not really being tackled by AI or machine learning, to be specific, because the impetus for development of those algorithms today generally comes from the technology side, right? And
That's right. That's right. So,
yeah.
And by the way, I'm not just quite just a clinician. I do lots and lots of things in the technology space. So I'm very interested in trying to be an early adopter and help with many of these things, but I really don't have as good a assessment of what's possible and what's not possible. But Florent, maybe we can take a step back for a second, and I can recount some of my experience, because I've been in radiology since the 90s. I started my career on film and have migrated to digital, and so I've seen some of the evolution of simpler technologies that predate AI, but have a lot of lessons to be learned that might help some of your developers. So I'd kind of like to start with kind of a conversation around 3D and how we used 3D early on, and what some of the problems were, and why we didn't really use them as clinicians, and what I'd like to see brought forward. Would that be all right?
Absolutely, yeah. I'm actually sharing a slide that has a 3D CT of the brain.
Yeah, so when I started as a resident, we were on film, of course, and then PACS came into my environment in the mid-90s. And when we had some of these data sets for PACS, we were kind of interested in how could we use some of these data sets, particularly for vascular studies, looking at the vessels, and use 3D for post-processing. Most of the early post-processing work required a workstation that you'd have to go over to, you'd have to load up the image data set onto that workstation, you'd have to manipulate it, you'd have to come up with selective images. And all of those things took a lot of time. And as a general rule, if you want clinicians to adopt whatever technology you have, I tell people you need to be a ripple, not a wave. If I have to get out of my chair to go use your technology, I'm pretty much not going to do it. I pretty much have to have everything within my workflow for me to really start using that at scale, to use it very frequently. In the case of 3D, I remember I was a trainee, and one of my mentors, Dr. Evan Fram, who actually built a PAC system, asked me to go do an interrogation of a data set. And I said, Dr. Fram, I have too much work to do. He said, that takes me over 10 minutes every time I got to do one of these. I have 15 of these on my list. I can't possibly do that. And he was very fast. He was a computer scientist and a radiologist. And he said, oh, that's baloney. So he challenged me that he could do it in less than, I don't remember what it was, 5 or 7 minutes. So the next case that came up, we literally got out of our chair. He walked over, he loaded it on the computer, did the manipulation, and it took him 8 minutes. And I said, there you go, Dr. Fram, I got 15 of those. There's no way I can get through my day if I have to do that. Ultimately, for 3D to really become part of my workflow, it had to become part of my PAC system, where there was literally just a button that loaded the data, did the interrogation, gave me the answers I wanted so I could move on. It would take seconds rather than minutes. The same is really true of any AI algorithm. It really has to be just something in the background that's super easy for me to use. If you don't do that, it doesn't matter really how much value that AI algorithm brings to me. I'm pretty much not going to do it at scale. I'm not going to use it frequently. And so the biggest barrier for me as a radiologist is not the AI algorithm itself. It's how you're going to integrate that into my workflow if you really want that to be a successful offering.
Right, and actually upstream from that, what you're really saying is that the tech industry often doesn't take the time to place itself in the shoes of the physician before they start designing a solution. And that's no different.
Yeah. And I have a lot of really smart technology people, and they're super excited about an algorithm they've derived that can provide a lot of value. But if you kind of think about how do I get that algorithm into my workflow, they haven't really thought through that. And so you kind of have to figure out some sort of on-ramp for that AI algorithm, a separate platform that allows it to become part of my workflow. If you haven't figured that out, you might as well not even start building the algorithm.
Right. Well, that makes a lot of sense, when you talk about it like this, but why is it? Well, let me ask you another question though. Today in your clinical environment, how many algorithms are actually being used clinically?
AI algorithms?
Yeah.
0.
I mean,
So,
that,
yeah,
considering the amount of noise in the industry coming from all the large and small companies, why is that today? I mean, I know that maybe the waves didn't start until a couple of years ago, but by now I would have expected at least one of those devices, because the FDA considers an algorithm a medical device like any other.
sure. Let me
To have
give
been
you another
cleared.
story that may give you some context. I went to our main meeting, the RSNA, gosh, 4 years ago, and at that time I saw a company, Montage Health. Wojin Kim, who I know from our community, developed this company largely from stuff out of Yada Look. Khan Siddiqui, another friend, developed this company. And basically what it allowed me to do, and it sounds kind of stupid, but it allowed me to do data analytics on my own reports. Think of it as a Google crawler for radiology reports, where it would consume my reports. It would allow me to see by referent, by type of imaging, by age of patient, all sorts of things. It would allow me to see all sorts of dashboards. And I looked at this and I knew that my EMR, which sounds kind of funny, my EMR could not give me these reports. It was a ton of work, and I had no way to get this. So I wanted this application in my hospital environment. And really, I wanted it for two purposes, just as an aside. I wanted it for quality assessment, which is a big driver for a healthcare system. But I also wanted it for research. I wanted to be able to figure out, do I have enough patients to even do a research study on a particular problem? Can I identify those patients? So I came back home to Dignity, and I started, going everywhere I could, asking people, will you help me get this thing? It literally took me 2.5 years to get through all the red tape within budgeting, but also privacy and security within my hospital to bring this application to the institution. Now, I'm pretty dogged when I want something, but you cannot expect clinicians, even if they're super passionate about your algorithm, to spend a couple of years, knocking on doors, trying to break down all the silos to get done the necessary budgeting, privacy, security pieces that is going to be required. And so really what I want is a single doorway where I can plug in my algorithms, and so I don't have to do that process over and over and over again.
So how to operationalize this technology is one of the key barriers to entry for some of this, right? It's not necessarily the
major
validity.
barrier. It's the major barrier. The production of the algorithm, that's the easy part. I can send you 1,000 cases of a problem. I can help you learn how to develop those algorithms. But even if you have the algorithm, you're going to have to figure out a way to get it deployed.
Right.
And that's really super hard.
Well, so that's a really important concept that we'd like to convey to our audience here, which is what are the top things that both hospitals and technology, the creation of those algorithms, need to be thinking about. And it's really no different than a startup company going to a venture capital firm presenting a new enterprise. What are the things that a VC will look for in the technology to the secret sauce, the process, the experience of the people building the technology? All of those things are ingredients that go into the decision making. And so before we even get to the operationalization of an algorithm, there's some real questions that need to be asked. So first of all, who came up with the idea that a particular algorithm needs to be developed, right? So we talked about the Glasgow Coma scale as one example. Well, that's an idea that came from a physician, right? It's not somebody from a technology company that said, oh, there's a problem with the Glasgow Coma scale. It's not using CTs. Why don't we improve it by applying an algorithm to it? So number one, are we trying to solve a real problem with an algorithm, or is it a mental or intellectual exercise to prove to ourselves that we can develop AI? So number one, our contention is that the idea behind, right, the shopping list of what the physicians will actually buy needs to come from them. It's when you go to Walmart, you already have a shopping list in your head, and you buy from Walmart because the product is already there. In AI, it's not the same thing. You actually need to tell the technology companies what you think you could actually use in the clinical sense, right? So first of all, identify a real problem. How many of those algorithms do you run into, Alan, that you go, okay, well, that's nice, but I can't use this today?
Yeah, if I'm going to invest in technology, there's the nice to have things and there's the have to have things. So there's certain things that make my world better, right? It makes it easier for me. There are certain things that I can't do for myself that the algorithms can provide. And really, Florent, I want to emphasize, I believe it's a true partnership between health and tech. Because I don't fully understand. I don't have advanced degrees in computer science and AI. I don't fully understand what is possible. And so I think it's an iterative process between the clinician and the software developer to come up with solutions that really make a difference. I'd like to emphasize one other thing, by the way. For any of you out there working in technology and healthcare, kudos to you, because this is a really tough space. It would be far easier for you to be in many other sectors to build out your products. Healthcare, however, offers you a real opportunity to make a difference in people's lives. I'm a big fan of Simon Sinek, the Start With Why, this idea of, why do I get up in the morning? What do I do? And clearly, if you wanted to build a business, I can tell you as somebody who's been an entrepreneur in healthcare is a really, really tough space, but it's also very, very rewarding. Now, you may not be able to think like a doctor as a technology person, but you can think like a patient. And you can start to identify problems that you may have seen for you or a loved one that you think technology might be able to solve. And if you can begin that conversation, but then bring a clinician in early to ask him, my loved one has this problem. I was noticing that XYZ, they're unable to do XYZ. How do you think about that? And if I were able to help you better understand this tumor or better evaluate this multiple sclerosis and follow it over time, if I was able to do that for you, would that be a value for you in caring for this patient? If you can get the clinician to say yes, that would definitely be a value to me, then I think you begin a conversation around, should this be developed? How much value does it bring? Frankly, is there a business model that applies to healthcare? And then that really becomes the kernel for something important. I can give you an example of what I mean exactly. One of the biggest problems in America, of course, is dementia, Alzheimer's. And we're constantly kind of looking at brain MRIs. And really what I'd like to be able to do is get a linear regression analysis of how much brain you have over time, because people are constantly losing brain volume. Now, that's not something that I can really assess as a neuroradiologist. I can tell you subjectively if I think there's been a change in the brain volume, but I can't tell you objectively. If I had an AI algorithm that allowed me to show over 3 or 4 or 5 scans the loss of brain volume, I'd probably be able to assess treatments and whether the treatments were making any difference in that brain volume. With those kinds of insights, I think we have something that's very, very powerful. It's amazing to me when I look at even the research industry. I have friends who work for some of the CROs, and literally they literally take out like calipers and they measure lesions all the time to give back for research. Human beings are not the way to measure some of these subtle changes over time. I need the tech industry to help me do that. I just need them to, point their gun at really important problems.
Well, that makes a lot of sense. And I'd like to go back to a point you just made about you don't have advanced degrees in computer science, but you hold a key piece of the puzzle that those who do have an advanced degree in computer science don't have, right? So it is truly a collaboration that needs to occur. So what is it that we could do to help close the gap between what the technology side and the healthcare side understand about this technology, right? Particularly in terms of AI. So clinicians want to uncover what's realistically possible with AI. So when you get beyond the hype, all the noise in our industry, what is it that you could be doing as a physician to educate yourself on what's possible in AI and be a contributor to the input the technology side really needs from physicians?
I'll tell you something. One thing that I think clinicians would find of great value is examples of what's the state of the state with AI today. So we make assumptions. The industry is really interested in promoting itself. And so we'll hear an AI company say, we can do X, Y, Z. But when I've had demos given to me, they really kind of overpromise and underdeliver a little bit. I'd really like to get a good assessment of what is possible. And I think many clinicians would be happy to say, look, this is my problem. I've got to count up the number of dots on a field, and it's just way too many dots to count and characterize. Can you accurately do this for me? Can you measure the amount of, when you talk about volume loss in the brain, one of the things I've really wanted is the ability to measure the amount of cerebral spinal fluid, right? We can tell the difference between brain and cerebral spinal fluid. Even coming up with a accurate, rapid way to quantitate fluid and fat inside the brain would be super. I can show you by imaging how to differentiate those, but I don't really have a sense of how strong the algorithms are to correct for that. So I think that getting a better dialogue between what is possible would help clinicians frame their ask of the tech community. And having more dialogue. I have to admit, we have an evolving center for AI here at the Barrow. It's run by a guy named Igor Barani. He's well known to the tech community. He was a co-founder of Analytic. I think we're starting to have that dialogue, but it's still pretty limited. I'm usually presented with an algorithm as opposed to having a conversation.
Well, but it seems like a cognitive dissonance to me in that we work with some pretty large organizations like Google and AWS, and they have physicians on staff. They actually employ physicians who have some of that perspective that you as a clinician have, Alan. And so what do you think is missing? Because they are working there, they are working on those algorithms, and they are providing physician perspective into the development of those algorithms. So what are we missing here? Why is the industry so far?
I think it's a relatively small group of physicians who were working on these problems. I think generally the physicians who go to work for Google and other AI companies, they're a different breed than the clinicians that I work with, right? They're highly selective, and they tend to have their own perspectives. I also have struggled with the execution. I need tech to help me come up with better solutions for execution against these algorithms. If somebody said, look, I have a platform that enables you to insert a library of algorithms into my PAC system, even if the algorithms weren't as good, I'd be super excited about that, because that would allow me to go to the hospital and basically come up with a single solution to then install a library of algorithms as opposed to an algorithm. The idea of repeating that process over and over again, that's just not scalable.
Well, what strikes me about this process is an analogy with Tesla. The automobile industry has been doing things for a century plus a certain way, and when Tesla came up with their first car, which was it was essentially based on the chassis of a Lotus, right? It wasn't even a Tesla. So they took a Lotus and they re-engineered it to be an electric car. But when they came up with the Model X, it was completely re-engineered from the ground up, right? They basically said, forget everything you know about automobiles today. Give me a completely electric vehicle that can be, autonomous for hundreds of miles, all the stuff that Tesla can do today that everybody said couldn't really be done. from the perspective of the automobile industry. So is there a little bit of this going on in healthcare where tech companies have been doing things successfully for a long time? They know how to do stuff, just like Ford and GM. And then healthcare could be the catalyst to help the tech industry think about healthcare a little bit differently and actually come up with new solution from the ground up.
Well, that's a pretty complex problem, but let me take a couple of things that might be of interest. So, healthcare as an industry is what I'll call a negative good. Nobody wants to buy healthcare. It's just something that they have to live with. That being said, it's 20% of our GDP, so it's a very large market. One of the things is you have to think about what's your role in life, what kind of company you're working for, and what are you trying to accomplish. So I spend a lot of time advising tech companies on what their product is and how to talk about that product to healthcare. So the biggest disconnect often from tech is that they have trouble translating the value they have into a problem in healthcare, and then secondarily they have trouble translating their solution into a relevant business model, how to buy and sell that product for the healthcare industry. Mm-hmm. So the tech person, often through a personal experience, sees something, comes up with a solution, and then is astonished that healthcare just doesn't, come screaming for that solution, that they have to have it. It really has to be translated to physicians, to hospital administrators, somewhat to IT, as to what the value proposition is. And then there has to be a way to buy that product. There are also kind of two approaches that I would tell you about healthcare. So generally, as a very, very large industry, most innovation in healthcare is at the margins. So most of it is, it's kind of like incremental change. For a relatively small company, you're going to have to function at the margins, because frankly, I've seen a lot of tech companies run out of cash because they have protracted conversations with the healthcare industry. You'll get your first customer. It could even be a large healthcare system. It could be the head of innovation who kind of likes what they see, and you think, oh my God, we've made it. I've got a customer. And oftentimes it's a death by pilot. You get your stuff in, they're not paying you yet, and the company dies from 1,000 cuts. It's delay. The company dies. And so for a smaller company, you have to figure out how to have a very clean message, how to have a very good business model that people understand, and then quickly move from pilot into paying customers. And so you're really at the margins. You can't do transformative change. Now, there's another group of companies that I would really love to see them get into tech in a different way. And I think maybe we're seeing a resurgence of this. So you may remember, almost a decade ago, Microsoft and Google made a play into healthcare. Microsoft had Microsoft Health Vault, and Google had Google Health. Both of those efforts, they poured in hundreds of millions of dollars, billions of dollars, and they both started and stopped. And realized that healthcare was a very difficult beast. I think you're seeing a resurgence now for those companies to look at how can we truly transform healthcare. Apple has had their new health kits been released. Google seems to have a real effort in healthcare. And so the question I would ask for those entities, you had the announcement with Berkshire Hathaway and Amazon, everybody's kind of looking at, this is clearly a broken system. Can we start from scratch and deliver something new? But that really requires a completely different player than the vast majority of companies, where they begin to think about, just completely starting from scratch and coming up with a new delivery system. But I think that requires a tremendous amount of capital to even consider that. And if they do that, I think it has to start in a very regional, limited way to see if they can make a difference.
So that's interesting, because what you're really saying there is that the traditional, the way we think about disruptors typically, right? The companies most likely to disrupt a market, to have transformative impact on an industry, are the startups, right? The ones that get the venture capital, that think differently, that are most likely to come up with something that competes with an established business model and therefore are going to disrupt that older business model. What you're saying is, yeah, that may be true in some industries, but in healthcare, the companies that are most likely to succeed at being truly transformative are the ones with the deepest pockets and are able to throw a lot of capital at
Huge
it.
capital. Yeah,
Before,
Steve Case talks
yeah.
about the third wave and how in the third wave you're going to have all these people who stop you from doing things because they're vested in the old system. There is no more archaic, highly regulated system that I know of than healthcare.
Mm-hmm.
And so if you're thinking of running a small tech startup and you're going to disrupt healthcare, good luck to you. But my bet is that you're much more likely to fail than truly disrupt.
Right. Well, so we're gonna be running up against a time limit because I want to give people an opportunity to get their answers from some of the questions they've asked here. So one important point is in this supply chain of images to algorithms. I'm sharing on my desktop an example of a problem that the industry runs into. Right. So what I'm sharing now is, what some of the pictures here are obviously a golden doodle doggy, and some of the other pictures right next to them are fried chicken. And you can see that there are some stunning similarities in texture and color between a dog and fried chicken. And so this is a very common problem we run into in the process of training an algorithm. And so what this is an illustration of is how much of a challenge there is labeling these images, right? Because physicians are creatures that are very much in demand, right? You have a job to do, you have many cases to read every day. And so if you're going to ask physicians to come on board with an AI company and painstakingly label images so that they can be fed to a machine learning algorithm, then what kind of business model do you need to have, right? Because this is not a very interesting activity for a physician, right? Intellectually, that would be a very boring task to label and mark hundreds of thousands or millions of images. So some companies have come up with some interesting models where they make the physicians equity owner, part owner of the company, so that the upside for them is in the future, not now in terms of cash, but equity in the future. But there's been so many opportunities like that out there. So how do you bridge this huge gap between the demand for machine learning, to use hundreds of thousands of images and millions of images to learn something, and the physicians that need to label those images effectively? Because we don't want, a golden doodle to be assumed to be a piece of fried chicken.
I totally agree. I've been approached by a number of companies who've asked me, my colleagues, my fellows, my residents to label exams, and that is a really tough thing to do. I have very little interest in doing that work. I mean, even if I get paid, I have very little interest in doing that work. My interest is really in trying to be transformative and make a difference. And so I think you're right, Florent, whether it's that they get equity or they feel part of a team, that there's a greater upside, that they remain vested in the algorithm and the clinical problem that's being solved. I think that that's a much more sustainable approach to how to partner on this. But I spent many years training in medical school and doing all this stuff to sit there and just kind of label stuff. That's not something that gets my attention. I do think the dog is cute, though.
Well, nobody said supervised deep learning is a fun activity, right? It's just the sausage making of AI. But to close the conversation here, I'd really like to go back to a term that you use, and I've heard you speak many times of what you term transformative healthcare. I'd like for you to tell us, what exactly do you mean by that? What would be a manifestation of or evidence of something being transformative in healthcare?
Oh, well, as you may know, I do a blog called Healthcare Pitstop. I do that largely out of frustration for where we are in healthcare today. The biggest disconnect for me in healthcare is that we as Americans are addicted to capitalism. We believe in capitalism. We think capitalism will drive lower prices and more value over time. And so we have worked to apply capitalism across every vertical, including healthcare. And the problem in healthcare is that our market has neither transparency in price nor transparency in value. And to be truly transformative in healthcare for me is the idea of being able to show outcomes for what we're doing. So a lot of the data science that I'm most interested in allows multiple data entry points and then an outcome for, did I make an impact for that patient? You know, my son's actually graduating with a degree in computer science, and I have a lot of conversations with him about this. For me, to be truly transformative in healthcare, I want to show that that good or service, that drug, that surgery, that device, whatever it is that was applied to the patient actually made a meaningful difference in that patient's journey. So when I'm looking for ways to apply technology, be it AI or other health IT, I'm looking for ways to show a measurable difference in the outcome of that patient's life. So I'm looking for people who are interested in coming along on that journey with their own skills to participate in that. You know, it's amazing to me. So when I read images today, I pretty much read them the same way I read them as a resident, 25 years ago. I have no idea when I look at a study and I say it's this or that, whether I'm actually right, because I get almost no follow-up on what happened to that patient after they left my MR scanner. And so if I was wrong, I don't really learn from that journey. I'm looking for ways to get both the imaging and contextual data to come together to give me much more insight into the value I'm providing. That frankly would give me a lot of job satisfaction and frankly would give the industry a lot more value.
That's very valuable input for all of us, Alan. Thank you for being here and a part of this. I'd like to ask you one last question, which
Sure.
is, where, if there is any kind of AI that's going to be transformative enough to be of interest to you as a physician, in your job today at Dignity Health, I don't mean to put you on the spot, but are you looking at any particular technology that would be what a technology company would consider low-hanging fruit that really needs to be addressed ASAP that AI can solve?
Yeah, so if I were looking at AI, and this is strictly speaking in my core expertise, which is as a neuroradiologist, right, imaging of the brain and spine. The low-hanging fruit, the easy problems are the big public health problems that I see that currently imaging is not well addressing. And so the first thing I would probably choose would be a rapid volumetric assessment of the brain that would allow me to correlate treatment with changes in the brain morphology. That would be number one. Number two would be the ability to look at multiple sclerosis plaques, which are usually very bright and easy to distinguish from the rest of the brain. An AI algorithm that could quickly assess those plaques and show me changes over time. That would be probably a second relatively easy but very useful thing to do. A third thing would be to look at the cortical surface of the brain, because I don't think we do a very good assessment in many mental disorders. And I think if we could get a better assessment of the cortical surface of the brain, which is something I cannot do as an imager, but an AI algorithm could possibly do, that would be probably a third place that I think AI can do something that I cannot do for myself. And then, of course, the combination of medical records, contextual data with imaging data, that mashup would be of a lot of value.
And you wouldn't expect that to be coming from your EMR or EHR or your PACS company?
Sadly, none of that happens today. Zero. My EMR, for those of you who don't know, my EMR is basically Quicken for doctors. It's a way to document what's happening with the patient so that healthcare can bill to an insurance company. It does not do a very adequate job in terms of data analytics at all. That's a real gap in the EMR.
Well, on this note, hopefully there's input that our audience has been able to get here. I don't know the makeup of our audience to the extent that how many of you are clinicians versus technology companies, but the main message of this conversation today with Alan is the main takeaway I get is that there needs to be a lot more collaboration upstream in the creation of tech between real physician input, meaning physicians who are entrenched in clinical workflows today and have the best perspective for what's really needed, and the technology companies that are best at providing a solution for those problems. And so, getting more of the collaboration, I think, could be a function of, in radiology, it could be a function of the ACR becoming, taking on a much more prominent role in being a sort of a broker between the clinical people and the technology people. I think that would be very reasonable. And I think the ACR is definitely going in that direction. I don't know if the cardiology industry is going in that direction, but radiology is just one of those subspecialties that really are the focus of a lot of AI companies. So in each of those subspecialties, there needs to be more of an effort to gather a shopping list of what physicians really want, and technology companies being able to address those collaboratively with the physician community. So on this note, Alan, thank you so much for being a part of this conversation. And I'd like for our Director of Marketing, Taylor, to let us know what questions we can address.
Thank you very much. It's been a pleasure to be on with you, Florent. And again, if you all see clinicians as your partner in developing these rather than a consultant for hire to do a small task, I think we'll come up with much better products.
Totally agree.
Florent, if there are further questions, I'm happy to try to address those via email or LinkedIn, but I'm happy to help out with your audience.
Taylor?
All right, yes. Hi, can you hear me?
Yes.
Yes, I do have a question here about what are your thoughts on a good strategy for small or large companies to engage with clinical partners to integrate, demonstrate value, facilitate regulatory approval? I think you addressed some of that already, Alan, but this attendee would like to know a little bit more about that subject.
Yeah, I think the regulatory, you're going to need separate consultants. Most clinicians are not really facile with the regulatory issues. But I think really reaching out to experts in the field early, and again, early, before you start to build, is probably your best strategy. You may think you know a problem, but most clinicians will give you 30 minutes or an hour of their time to try to work through something that they're passionate about.
And also to add a little bit on the regulatory side, the FDA, I don't know if this is the same way in Europe, but the FDA at least considers AI a medical device, right? So if they're going to be actually measuring the efficiency and the safety of a device based on outcomes. And so rather than measure the efficiency of the algorithm itself, the FDA typically will look at the efficiency of the physician with or without that algorithm, right? So if the physician is more correct more of the time with the algorithm, chances are that algorithm is going to get clearance. But if the physician is not showing any kind of improvement in performance or less mistakes being made thanks to an algorithm, chances are they need to go back to the drawing board.
Yep.
Any other question, Taylor?
I think we're going to have to follow up with the rest of them offline.
That's fine.
Happy to do so, Taylor, and I apologize for being a few minutes late.
Not at all, not a problem. Thank you so much, everybody, for attending our webinar today. We'll be making an announcement for our next webinar very soon, and I encourage everyone to visit healthcarepitstop.com. This is Alan's personal, not blog, it's actually a podcast. He has some very interesting people that he interviews routinely on his show, and I think you would benefit from some of that input as well. So thanks, everybody, and I want to wish everybody a great day.
Take care. Bye-bye.
All right. Thank you.